I'm Anthony Leeds, and it's my pleasure to welcome you to the next program in the series that we're presenting at this particular time in relation to problems related to diabetes and other obesity-related comorbidities. Many viewers will have listened previously to Professor Mike Lean talking about the diabetes remission trial, which has been undertaken in the United Kingdom, and the way in which this is now being rolled out across Scotland and across England quite successfully with very good results. And of course, the question that arises from this is, could this be applied elsewhere? And today I'm joined by Professor Shahrad Taheri from the Department of Medicine in the University of Leicester to talk about the application of this type of approach in other parts of the world, but particularly in the Middle East. Shahrad, thank you for joining me. Perhaps we should begin, for the benefit of those who didn't perhaps hear the earlier episodes, by defining what we mean by diabetes remission.
Well, diabetes remission is turning to be a very complex issue and contentious issue. Initially, when we were thinking about diabetes remission, we were thinking about a state of disease where the individual will be out of the diabetes range in terms of glycemic control, measured through hemoglobin A1C, which is a measure of blood sugar control in the previous 3 months, and being off all medications. And this was the definition that was used, that set up the idea of remission in the first place. So from where we started, our sort of definition was that people have to be off medication for at least 3 months, and their HbA1c has to be below the diabetes range. Now, HbA1c in the diabetes range is 6.5%, so anything below that then is considered to be either pre-diabetes or normal blood sugar control. And if it's off medication for 3 months, then that's diabetes remission. Now, other people have argued that you can have diabetes remission with bariatric surgery, for example, and that's an intervention without medication as well. And also you can have it with medication as well in terms of being within the glycemic control. However, most of the medications that we use for management of diabetes and obesity have effects on blood sugar control. So there's a debate as to whether this is treatment or whether it's remission or not.
Yeah, but all of the papers that describe this are fairly clear about which sort of definition they're using. And as a result, or almost in parallel with what was going on in Glasgow and Newcastle, you actually undertook studies in Qatar, didn't you? What was the specific reason as to why it was necessary to repeat the study in that part of the world? Well,
actually, the idea of DIADEM actually came before DiRECT, and the study ran parallel to it. So the idea came from 2 aspects. One was because I was running a large obesity centre within the UK in Birmingham. And one of the observations that we were having is actually, is it possible to actually reduce the burden of diabetes in terms of medication and things through weight loss? And there were people who were also undergoing bariatric surgery who were actually going to diabetes remission as defined by the bariatric surgeons at the time. And then my experience was with one patient, and this shows you the power one patient can have. I had a patient who had terrible diabetes and had sort of diabetic eye disease and difficult to control HbA1c, even on insulin. And this patient happened to have hepatitis and ended up having a liver transplant, at which point her diabetes completely disappeared. And we wrote this up in Diabetes Care Journal and showed that actually the liver has got such an important part to play. So removing potentially fat within the liver was just as important. So that's how the idea of DIADEM came about, by through clinical observations, and then through one single patient that said, actually, look, the liver is just as important as the pancreas, so we need to take care of that. Then we actually did, the way we did the studies were actually like, I'm sure you're aware of it, we did like Star Wars, we went backwards. We did DIADEM 2 first, and this was a study of looking at people with really advanced diabetes who were on insulin, and the study was carried out with Gary Frost, yourself, and Adrian Brown, who was my PhD student at the time. He was running it. Mm-hmm. The idea was, can we reduce the burden of diabetes in people who were insulin treated? And we managed to get about 1/3 of people off insulin through a total diet replacement approach. And this showed that actually it is possible to reverse diabetes, a reversal of treatment. And then the next question was, can we actually go earlier in diabetes? So we knew from bariatric surgery, for example, that people who were younger, had earlier disease, were on less medications, were not insulin treated, were more likely to go into remission. And Qatar became the sort of the epicenter in terms of being able to do this study, because Qatar has got a high prevalence of diabetes. It's about nearly 1 in 5 individuals who are affected with type 2 diabetes, and diabetes tends to occur at a younger age in Qatar. So the idea of DIADEM 1, going backwards in our studies, was actually coming to actually reverse and put people into type 2 diabetes remission. And this took a longer time to conduct, because it was in Qatar and was one of the first clinical trials to be done in the region. It was the only clinical trial to be done in the region, in the Middle East and North Africa region, to answer this question. And we systematically looked at all the studies that have been done in terms of weight management, and there weren't many. So I had very little to go with. So that's why, and it took a long time to set up a clinical research infrastructure in Qatar. So we had to set up a clinical trials unit, set up all the infrastructure to be able to do that. And that's why it took a little bit longer than DiRECT. So we managed to do the study in Qatar, and there are certain differences in terms of what the study was about compared to DiRECT. First of all, the individuals were younger than DiRECT, and that shows the sort of incidence and prevalence of diabetes in the region that occurs about a decade earlier than what happens in the UK. So they were 10 years younger than DiRECT. The second factor was that they were coming from 13 different countries across the Middle East and North Africa. And this is the beauty of doing clinical trials in Qatar, is because you have such generalizability with people coming from all over the world to work in Qatar. And the next factor was that about 70% of them were men, which is very unusual in so this kind of trials. And that's, again, a reflection of demographics of Qatar. And initially, and the other factor that was really big in terms of DIADEM, but actually two factors. One was that we had unsupervised physical activity, and the idea was to get people not only to, first of all, use a total diet replacement to lose weight, but then reintroduce diet to be able to manage a good, healthy diet, which was a low glycemic index diet, but then add exercise to that to be able to maintain that weight loss, because we know that exercise is not so good for weight loss, but good for weight loss maintenance. So that was one factor. And the second factor came from my previous work, where we showed, really long time now, it's like over 20 years ago, 2004, where we showed that short sleep duration was associated with obesity. And this was the first study that show it in a large population. Now you read it in all the journals that sleep is so important, and it's now being realized more. So we showed that in 2004. And one of the factors that we also included in the behavioral intervention of DIADEM included sleep. So quite subtle differences. And this subtle difference results in a much more remarkable outcome in terms of type 2 diabetes remission. And we defined type 2 diabetes remission as being off medications for 3 months and having HbA1c below the diabetes range. And this has now been the accepted definition of type 2 diabetes remission by a consensus statement, which is good, because DIADEM just set that up with that idea. Now it's an accepted sort of consensus definition. And we showed that 61% achieved type 2 diabetes remission, which was really much higher than what they were observing in DiRECT.
That was 1 year. Did you manage to follow any of them for longer than 1 year?
We're looking at longer term data with that. And the other point I want to make is about 1 in 3 of them were within the normal range in terms of blood glucose. So they weren't even pre-diabetes, they didn't have pre-diabetes, so they were within a normal range. And about 70% of them had normal blood pressure. That means having a blood pressure of 140/90 or less than 140/90, and being off medication. So we've not only managed to improve them in terms of diabetes, but also in terms of cardiovascular outcomes. And this shows that it's fairly generalizable. Now, as you're aware, there are other studies that have been ongoing. So there was a study in Australia which is used a different formula, total diet replacement, than what was used in DiRECT and DIADEM, and they showed very good results as well in Australia. And people across the world are interested in terms of setting up diabetes remission clinics and having kind of interventions. Now, the main problem with diabetes remission is people say if it's related to weight loss, then obesity and excess body fat is a chronic disease, and it's always inevitably is going to come back. And that's always the case, and this might explain why the results may not be great down the line. But based on the data that we have, for example, if you look at the Look Ahead study, where they did a large intervention, again, not exactly the same population as DiRECT and DIADEM, but what they showed that actually the longer time people spend in diabetes remission, the less likely they're going to have cardiovascular and chronic kidney disease in the long run. So the idea is, even if it's for a short time, keeping people in remission is a really good thing to do.
So in actual fact, one of the other interesting things is that there are now ways of looking at markers of risk that go beyond the sort of normal clinical tests that we were able to do for decades. And you actually looked at the participants in your trial, the DIADEM trial, and also the DiRECT trial. And you actually produced some really quite interesting clues about which markers might be the most useful ones, and also point us towards mechanism. So can you comment first of all on this relatively new technique of looking at quite a lot of proteins, thousands, hundreds of proteins that are present in tiny samples of blood, which seems quite an extraordinary thing to do technically, but that was what was done, and you reported those results. What did you find?
Well, as you know, proteins are basically the backbone of how we function in our body. So the proteins are enzymes that, for example, affect chemical reactions in the body, receptors that actually deal with signals that happen in the body. So proteins are absolutely essential in terms of understanding, and proteins are next in line after genes. So your genes determine what proteins you have, and the proteins then basically orchestrate what's happening in your body. So they're we have about 20,000 proteins or more that are actually managing every single aspect of our body. And some of them appear in the circulation. And in the old days, the way to work out specific hormones, if you had a hormone in mind, for example, or a protein in mind, what you would do is an assay called an immunoassay, which is using an antibody to measure it. And they're incredibly difficult to develop. It takes a lot of time to actually then measure, and you could only measure one single protein or a few proteins. But now there are different technologies. So one of the technologies that we use was what I call sermomers, which bind multiple proteins, and they can be then amplified and then measured in the lab. And it's possible to measure up to, the numbers are increasing every year up to now. From the last time I heard was you can measure up to 7,000 proteins in the circulation.
It's extraordinary.
Yeah, it's really amazing, because the other methods of doing it, apart from enzyme assays that measure individual proteins, is to use what's called mass spectrometry, which is really hard to do. And what happens is when you put things through the mass spectrometer, you have to basically get rid of all the proteins that are really highly abundant, like albumin and things like that, and they interfere. So it's not so easy to do. So these new technologies are amazing. And then what you can do with these technologies is then you can see which proteins sort of work together as a pathway, and which ones then together would predict a certain disease or certain outcome that you're interested in. And then you can also then see, based on these proteins, who's responding, who's not responding. So it's really exciting. Allows the future, which is what we're interested in personalized precision medicine, which is actually tailoring that individual so you get it to the right patient at the right time with the right treatment to the right team to get the right outcome. It's really amazing. So what we did was we teamed up with the DiRECT study, and we used what are called proteomic panels. So these are the panels that predict a certain condition or certain disease. And based on these panels, what we found was actually liver fat was improved with weight loss. And this happened from 3 months, because we had data, we had these proteins with DIADEM every 3 months, whereas DiRECT had it at initial and 12 months. So at 3 months, when the majority of the weight loss occurs, that's where the sweet spot. So liver fat was reduced based on proteomic panels. The VO2 max, was a measure of fitness, improved. There was a reduction in body fat. But what was so interesting is there was also a reduction in the risk of cardiovascular disease based on the markers, because these markers can be used to predict cardiovascular disease. Of course, we didn't have sufficient numbers. Even with the DiRECT follow-up that was shown, they didn't see any excess cardiovascular disease or excess cardiovascular reduction, because the numbers were not enough. So what's reassuring about long-term follow-up DiRECT is there was no additional cardiovascular risk. What we showed with the proteomic panels, that actually based on the panels, your cardiovascular risk is reduced. And this is well what was observed in the Look Ahead study, and also studies coming out of Hong Kong looking at diabetes remission, where they're very clearly shown with that. And I can give you hot off the press data as well now. We've looked at panels that actually predict dementia, and this was reduced in the individuals in DiRECT and DIADEM.
So those linked to markers of inflammation, because other people's proteomic studies with weight loss have shown that a set of markers of inflammatory activity were also changed. Were there inflammatory markers changed?
But it's likely that these are particularly involved, but I can't tell you about the panels, because the panels are especially for the company, and I don't know the exact composition of those panels. But we've measured 3,000 proteins, and there's a reduction in inflammatory markers. Some of the factors, for example, that we're looking at, things that sort of promote hypercoagulation, things like that, tends to be improved in terms of with weight loss, and also factors that are related to liver health also improve as well. So a lot of the, obesity is excess body fat is really complex, because when I did endocrinology, I was very much interested in the gut, and the gut was the largest endocrine organ. But now we know that the adipocyte is the largest endocrine organ, producing so many different hormones and cytokines that affect the body. And this actually absolutely makes sense, because body fat is so important for species survival. And again, we're seeing the similar kind of sort of inflammatory markers that relate to excess body fat. They change in terms of weight loss.
So what you also mentioned earlier on, of course, the changes in liver fat, and a subset of the DiRECT people in the Glasgow and Newcastle study were actually subject to scans by Roy Taylor up in Newcastle, and he showed very clearly by direct nuclear magnetic spectroscopy that in fact the fat in the liver went down really quite dramatically, very quickly, as you suggested from the results from the study you've just described. And so what that does do, in fact, is tell us that losing weight is really terribly important as far as liver disease, and liver disease related to fatty liver is, of course, now very prevalent across the globe, isn't it? The latest figure I saw was 38% of the adult population across the globe almost certainly has some degree of liver disease, but it's a spectrum. And would be good, we can talk about that next time perhaps. But what we need to do is to end by just giving a little bit of guidance to people who haven't got access to these very sophisticated measurements at the present time, and just indicate what we might do. Underneath this panel, there's always some text and some links to appropriate websites where, for example, you can look at diabetes risk and so on. But do we have any sort of general statements that we can make for people who think they're at risk of diabetes? And of course, you can check that by going and looking at some of the online websites where you can assess individual risk and then go on and see a doctor if necessary. But can we give general advice about the importance of weight loss in preventing diabetes and some of the other comorbidities, including fatty liver? But we'll come to that next time as well. Any general comments?
I mean, this is a really big challenge, because how do we measure excess body fat? Well, this has been debated in terms of how do we find that out? How do we know we're at risk in terms of excess body fat? And traditionally, we've used what's called the body mass index, which is your weight in kilograms divided by your height in meters squared. But we know that the BMI in terms of the European population, a BMI of 25 to 30 is sort of considered to be within the overweight range, and greater than 30 is within the obese range. But it's different in terms of ethnicity. So different ethnicities have got different risk factors in terms of developing complications of obesity, such as fatty liver and type 2 diabetes. So you have to use ethnic specific cut points, and they tend to be lower in the South Asian population. Well, so initially it's worth looking at the body mass index. So, for example, depending on where you're from, if you're from Bangladesh, for example, a BMI of 21 could be excessive for you in terms of excess body fat. So what we sometimes recommend is measuring something called a waist-height ratio. You measure your waist, which is basically around the sort of belly button area, and then divide that by your height. And if your waist-height ratio is more than half, more than 0.5, then you're at risk of having excess metabolic disease. So if you suspect that that's the case. But now we also have what we call bioimpedance scales, measures that send an electrical signal that can measure the percentage of body fat, and this determines whether you have excess body fat or not. So if there's any excess body fat, then there's a risk of having complication in terms of diabetes. And when you combine that with a family history as well, then you're at risk. So what do you do about it? Is we know that in terms of prevention, and this comes from the large diabetes prevention trials, that actually about 5 kilos weight loss is what's needed in terms of achieving preventing development of type 2 diabetes. I have to say now, even we have a stage called pre-diabetes, which is high risk of developing diabetes, and people are now interested in pre-diabetes remission with weight loss. So to achieve diabetes remission, that is going to normal blood sugars, and then it's possible to do that with smaller amounts of weight loss, about 5 kilos. And for type 2 diabetes remission, we're talking about 10 kilos and above. So 10 kilos is the sweet spot for type 2 diabetes remission. Other ways that people could look at it, actually blood glucose is a very good measure of what's going on with you, and glucose variability. What we find, actually, blood glucose is really intimately related to how much fat there is in the liver. And you could easily measure these using glucose sensors now, which is continuous glucose monitoring, and that gives you an indication of how your sugars are going, whether you're in the pre-diabetes range or the diabetes range or not. And the problem with these is they're fairly costly at the moment, but we're hoping that as there's more competition and interest in measuring glucose, it become cheaper over the long term.
Okay, good. Thank you very much. I think that would be a good point at which to stop this week. We've discussed fatty liver and the importance of it, and we will consider that next week. But Shahrad Taheri in Leicester in the United Kingdom, thank you very much for talking to us. Thank you.
Yep.
Thank you. Yeah.